Sir, we are live now. With all your permission, I'm starting this session.
Please go ahead.
A very good evening, everyone present here. I welcome all the participants on today's session. Let's welcome today's speaker with great honor, none other than Dr. Anil Gangju, sir. Sir has done MBBS, MD in dermatology, venerology, and laparoscopy, leprosy, and consultant dermatologist as Skin Innovation Clinic, the World of Aesthetic, Model Town, New Delhi. And for today's session, the topic is superficial fungal infection, current therapy, trends in therapy. And let me tell you overview of the topic. In today's session, let me tell you over of the topic, the current trends in treatment, current trends in therapy of superficial fungal infection primarily involve the use of the tropical antifungal agents such as azoles, alamines due to their effectiveness and reduced risk of systematic side effect. In this session, sir will discuss about the drugs and innovative delivery methods like nanoparticles and lysosomal formations to enhance the drug's prevention and efficacy. By taking not much time, I would like to invite sir and hand over this session to sir. Over to you, sir. Kindly proceed from here.
Thanks, Faraz, and thanks, IJCP, for giving me this opportunity to address the audience here. It's indeed a pleasure, and I'm going to talk about not so much about therapy of the fungal infections, but the menace of fungal infections, which has come in the recent past in our country because of the recalcitrance and difficult to treat and recurrent infections of the superficial fungal infections. So superficial fungal infections, or superficial dermatophytosis as it is called, is the most common fungal infection that is seen worldwide happening on the skin. And according to the WHO, the prevalence rate of the superficial fungal infections is to the tune of about 20 to 25% of the human race worldwide. And the most common causative agents include the trichophyton, the microsporum, and the epidermophyton. India is not far behind. In fact, India has had a very bad explosive infection of fungal infections across the country, and it has become more or less endemic, or epidemic, or hyperendemic in the recent past, with so many people and so many families and so many colonies affected at the same time. We have seen a resurgence of the infection, and over the last 5 or 6 years, most of our OPDs are now full of patients with the superficial fungal infections. In fact, the prevalence rates in various studies have been quoted to be to the tune of about 27%, and most of them are caused by dermatophytes, and about 24% by non-dermatophytes. Now, tinea corporis, or fungal infection or ringworm of the body, skin, is the commonest clinical presentation, and 10% of the patients with dermatophytosis are treatment naive. That means most of them have taken some treatment or the other when they reach us. So either the local chemist gives them something to apply or take, or a quack, or their general physician for that matter. Most of them are treated. Only 10% will come to us without having had taken treatment. And the recent review suggests that the common species of superficial fungi like the Trichophyton rubrum, Trichophyton mentogrophytes are the common agents that affect the skin and the nails, and Trichophyton tonsurans, violacum, and Microsporum canis are the ones that preferentially affect the scalp hair and the scalp. Now, because of this recalcitrance and difficult situation with fungal infections, we have come across new terms in the recent past, which include chronic dermatophytosis. When we started our practice way back around 30 years back, we didn't have anything like chronic dermatophytosis happening. All these patients used to respond well to treatment, and it would not persist. But in chronic dermatophytosis, it persists for more than 6 months. Recurrent dermatophytosis is the infection that occurs within a few weeks of stopping or completion of the therapy. And recalcitrant dermatophytosis is something that does not respond well at all, and there is some degree of infection persisting for a long time. And as I told you, we have seen the prevalence increasing to a large extent over the last few decades. And because of this, the antifungal therapy has undergone a remarkable transformation in the recent years. Newer and newer molecules are coming, newer vehicles for application, newer delivery systems, so that it can be absorbed better and works better. And then there is the emerging threat of antifungal drug resistance that has been recently, talked about, because we are seeing difficult to treat patients or patients not responding to antifungal. So we think of resistance also. But this resistance has not been well studied as far as the antifungal agents are concerned. Like in antibacterial resistance, we have a lot of literature available which proves which molecules have which molecules the microbes are resistant to, etc. In fungal infections, we do not have so many studies. Now, we see families and colonies affected at the same time. Some respond, some do not respond, and reinfection or recurrence are after a complete remission is a very common occurrence nowadays, and it's almost a rule. So every patient will come back with some degree of infection, and this is a common scenario in our OPDs these days. And if you have a patient who comes in and shows you a lesion of tinea corporis, tinea cruris, and if he has family members accompanying him, and you disrobe those family members, you'll definitely find some sort, some type, some severity of fungal infection in other family members also. So it affects the families, and this is one of the reasons for the infection for going on for a long period of time, and because of what is known as a ping pong effect. So one patient is being treated, the family is not being treated, the other family member gives the infection back to the patient, that family member is treated, then this patient gives it back to the family member. So it goes on from to and fro, the ping pong effect. Now, because of this difficult situation, our association, formed a task force to fight this recalcitrant tinea. This is known as ITART, and this task force of the Indian Association of Dermatologists, Venereologists, and Leprologists gives us frequent inputs as to how we should be dealing with difficult to treat fungal infections or tinea. And then there are conferences happening how to fight this menace. So that shows the degree of severity and degree of seriousness of the situation. Now, why do we have treatment failures? Let's delve more into the causes of treatment failures. Number one is the patient causes. The patients do not adhere to the treatment properly, or there is reinfection happening from close contacts, like I told you, the ping pong effect from family members, or there could be doctor factors, like the patient has not been given proper treatment, proper drug, proper dosage, proper duration, or the diagnosis is wrong in the first place. And last of all, the fungal resistance. The fungi are resistant to the antifungal that you are prescribing. So all these can be a reason. So host factors that lead to drug resistance include, the immune status of the host. If it is not good, then the drug may not affect well. The infection site, for example, the flexures will have a severe degree of infection. They will not respond well to our common therapy. Severity of infection, presence of foreign materials at the site of infection, which act as nidus and do not allow the infection to be treated completely, and poor adherence on the part of host. Then there are drug factors. There are two types of antifungal drugs: the fungistatic, which stop the replication of the fungus, and then we have the fungicidal drugs, which cause the death of the fungus. So the fungicidal drugs are preferred than the fungistatic, because fungicidal drugs will eradicate the infection completely compared to fungistatic drugs. So if you have not used the right drug, that might be a reason for a resistance to treatment. And then other factors of the drugs, like the pharmacokinetics, the drug-to-drug interactions, etc. And then there are fungal factors. Now, fungi are always on the lookout for developing, ways and means to counter the antifungals, like the bacteria are. So they keep on changing their genomes. They keep on, developing new enzymes, new morphologies, so that they can escape the cidal or static action of the antifungals. Now, at the same time, you have to be careful and rule out, immunocompromised or immunosuppressed conditions like diabetes, HIV, anemia, or patients who are on immunosuppressive drugs, anti-cancer drugs, steroids, etc. They can be the ones who are not responding to treatment well. Now, factors that lead to poor adherence amongst the patients include the long duration of therapy. Usually, we have to give the drug for a long period of time, and the concern amongst the patients, because they are using it for a long period of time, about the side effects. So this you can address by giving them intermittent dosages. Poor understanding of how to take the medication. If the patient doesn't know how to take it, counsel them properly. Complexity of therapy should be avoided as much as possible. And you should develop a good rapport with the patient, spend more time with the patient, and make him explain it to him how to take the drug, how long to take the drug, and the importance of adhering to a proper schedule and duration of the drug. Now, reinfection from close contacts can happen these days because of people staying in clustered small homes, in hostels, in gymnasia, hotels, contact sports where there is contact between the people and the patients, and they can transmit. Infected towels, beddings, old shoes, all this can transmit the infection. And then we have the menace of corticosteroids in our country. The topical corticosteroids in combinations are easily available from the next door chemist, and people can easily pick it up and they use it. They are also prescribed by many, given by chemists per se, or sometimes prescribed by general physicians also, and that leads to to decrease in local immunity in the skin, side effects in the skin, and also recalcitrance of the fungal infection. So a proper knowledge of antifungal drugs and preventive measures is very important in preventing the recalcitrance of the disease. Now, there are various reasons that have been laid down for the recurrent and recalcitrant dermatophytosis. It is not only the drug resistance. It can be irrational use of steroids, particularly the combinations that are available. We have double, triple, quadruple combinations available, unnecessarily having very strong steroids. But steroids are not the only reason that are responsible for this current situation. There are so many other effects, the ping pong effect, as I told you. So multiple members of the family being affected and the disease traveling to and forth. The changing fashion scene in the population. So the jean culture, the tight-fitting clothing, the occlusive footwear, all these can promote infections and lead to difficulty in responding to the treatment. Inadequate dosing and duration of antifungals, poor compliance by the patient in treatment, because the treatment has to go on for a long time. Sometimes they don't want to. Comorbid conditions, if they are present, like obesity, diabetes, all this, and overcrowding. All these are factors that can be responsible for severe continuous infection. Now, I'll give you an example of one of my patients here. First of all, the morphology of the fungal disease has undergone a tremendous change, and nowadays we may find a very subtle erythema on the lesion, and only if we are aware that this could be tinea, we can go to the edge of the lesion and find this, the active margin of the lesion, which will show and give you the diagnosis of tinea. So if you look at the face, you can hardly find anything. This patient is complaining of itching, has a little erythema. You can't make the diagnosis, but you follow and go to the edge and you will find a very active margin here. So this gives you the diagnosis. Now, what is important is that this patient, when I asked this patient, what has she been using on the face?
मुस्ता जी, आप क्या-क्या दवाइयाँ लगाए हैं?
मैंने लोबेट ही लगाया है।
कितनी देर से लगा रहे हैं?
मैं जब से निकला तब से।
कितनी देर से निकला हुआ है?
मैं जनवरी बता रही हूँ।
जनवरी से, मतलब आज अगस्त।
लगाए,
कभी-कभी लगा।
जब ज्यादा हो जाता तो लगा लेती
तो
हूँ।
अच्छा लगता है जब लोबेट लगाती हैं?
हाँ, थोड़ा आराम मिल जाता है।
किसने दिया था लोबेट आपको?
लोबेट मेरे घर में पड़ा हुआ था, या दाद हुई थी यहाँ मेरे बेटे को।
अच्छा जी।
तो उसने लगाया था, तो उससे मैंने लगाया तो आराम मुझे मिल गया।
So this patient is applying Lobate, which is the highest, which has clobetasol propionate, which is the highest in the class of topical corticosteroids as far as the efficacy is concerned, and it is associated with a lot of side effects. So it can lead to recalcitrance of fungal infection. It can lead to so many side effects locally. Similarly, a patient, another one, you see subtle inflammatory changes on the face, the margin at the top on the forehead. And again, this patient has been using a steroid.
आपको ये रैश जो है स्किन पे, फेस पे जो आ रही है यहाँ ऊपर, ये कब से है?
ये लास्ट 15-20 दिन से है।
ओके। और जो आप इस पे क्या लगाते हैं, फेस पे क्या-क्या लगाते हैं आप?
बैकनावेट जीएम विद फेयर एंड लवली।
ये कब से लगा रहे हैं?
डेली 10 साल से लगा रहे हैं।
ये क्यों लगाते हैं जी?
एडिक्शन है, मतलब एक आदत हो गई है, नहीं लगाएं तो रेडनेस हो जाती है फेस पे।
ओके,
एडिक्शन एक।
तो आपको किसी ने बोला नहीं बैटनोवेट ठीक नहीं है फेस के लिए?
बैकनावेट ऐसा सुना भी नहीं था किसी ने, कभी मैंने
So basically, people are not aware. There is easy availability of these steroids at the chemists, and chemists give it easily because there's no restriction. So that is also creating a havoc, and people are spoiling their skins, and the infections are also becoming very, very recalcitrant. Now, one important mycological, change that has happened in the superficial fungal infections recently is that Trichophyton rubrum, which used to be the common cause of fungal infections superficially earlier, has now given way to a more aggressive Trichophyton mentogrophytes. Now, Trichophyton mentogrophytes is associated with a more aggressive disease. It is a more aggressive organism, does not respond to treatment easily, and that's why leads to a more recalcitrant and chronic disease. So that is one reason which could be responsible. Also, Trichophyton rubrum is a more fragile organism compared to Trichophyton mentogrophytes. And one of these studies, interesting studies on persistence of the spores, fungal spores on towels, showed that Trichophyton rubrum spores survived for less than 12 weeks on towels, while as Trichophyton mentogrophytes spores survived for more than 25 weeks. So Trichophyton is a more aggressive organism which has come up recently, is causing more of infections. And in fact, this highlights the importance of disinfecting the clothing. And the best way to disinfect the clothing is by washing them in hot water at 60 degrees centigrade. So if you wash the clothes in hot water and then dry them in sunlight, sunlight is the best, most effective disinfectant for dermatophytosis. So wash in hot water, dry in sun, and then wear. So that is one way that you can use to reduce the reinfections and recalcitrants. And most of the studies across the country are now showing that mentogrophytes is on the rise, and most of the infections now are caused by this. So these days we find very severe and widespread and large lesions happening all over the body. Earlier, we used to find a small lesion in the groins and we would treat it in 2 weeks and it would be gone. But no, gone are the days. And this is how we see. And this is mostly because of misuse of steroids and other, factors. And we see different morphologies. We see double-edged rings of tinea. You can see how severe it is. You can see very inflammatory tinea, which is very typical of mentogrophytes, which is an aggressive organism and can induce a very inflammatory response in the skin and cause inflammatory tinea. And then we can see this we would not see commonly earlier, tinea faciae in adults, or facial involvement in adults, or scalp involvement in adults. We would not see this, commonly earlier. Now we see it very commonly. So that's because of the changing, patient profile, the changing microorganism profile, etc. Then these inflammatory pustular lesions, these are not also, uncommon now because of the more severe disease. And then we have the steroid menace that leads to, side effects like stria, like thinning of the skin, atrophy of the skin. You can typically see it here, a background of tinea which has become recalcitrant, does not respond, steroids being applied, and there is thinning of the skin and stria. There is thinning of the skin here. You can see the veins easily, visible through the thin skin. Now, it is also important to understand that more than the resistance to the antifungals, it is the clinical failure that we are facing, and which is because of the multiple factors, not only drug resistance, but because of the patient factors like the changing lifestyle, the tight-fitting clothing, the gene culture, wearing clothes, without washing, not disinfecting them properly. All these are responsible for clinical failure rather than a resistance. And this resistance or clinical failure can happen because of multiple factors: the drug factors, the fungal factors, the host factors, the environmental factors. Now, if we look at antifungals, most of the antifungals act on this pathway of ergosterol synthesis. Ergosterol is vital for, for the normal maintenance of the cell wall of the fungus. If ergosterol cannot be synthesized, the fungal cell wall breaks down and can die, and that leads to death or stasis or further proliferation of the fungal cell is stopped. So most of the antifungals like L-ilamines, like azoles, the morpholine derivatives, etc., they act on this pathway at various levels, various enzymes, and they decrease or don't allow the ergosterol synthesis, which is so very vital. Now, resistance to the antifungals like azoles has developed within the fungi because of alteration in the drug influx or the entry of the drugs into the fungal cell, or alteration in the target enzyme, or alteration in the drug efflux. I'll quickly tell you about this. So basically, the azoles enter into the skin, into the fungal cell through unknown mechanisms and act on the enzymes which are important for ergosterol synthesis. Now, what the fungus does is that it changes this enzyme, the morphology of this enzyme, so that the azoles cannot act on it. Plus, there are these efflux pumps in the fungal cell wall, which remove this drug from the fungal cell, and there is an over expression of these efflux pumps in these fungal cells, and that's how they reduce the activity of the antifungal agent. So they throw out the drug quickly out of the cell, and therefore the azoles become ineffective in the drug. Finally, so one is enzyme morphology change, and increase in the efflux pump is important. The common tests that we do in our day-to-day practice is a KOH, and microscopic mount. It can be easily done. Fungal cultures are done in people who are not responding properly, have recalcitrant disease, and in whom large body surface areas are involved. There is one dermoscopy that we do these days, which helps us to, one, make the diagnosis, and two, find out the people who are difficult to treat and may have a long-standing disease. And one important factor is the infection of the villus hair. So, we have the terminal hair and we have the villus hair. The thick black hair are the terminal hair. The thin, less pigmented hair are the villus hairs. So if the villus hairs are affected, it is very likely that the disease will be chronic, because the infection in the villus hair is not easy to control. So these are some of the examples of difficult recalcitrant tinea, a tinea showing an eczematous reaction. This patient was put on terbinafine, levocetirizine, and topical luliconazole, responded well, but then another patient similar, put on a similar regime and responded well. But what is important is that both these cases, the treatment was continued for 3 weeks after the remission happened, for a lasting effect. So in the present day era of severe recalcitrant dermatophytic infections, we need to treat with higher doses. Sometimes we need to continue the treatment for double the usually recommended time period, and we need to avoid topical corticosteroids. So I'm not going to go into the details of this. These are the common antifungals that are available. These are the topicals. And there's a long list of topicals like azoles, like allylamines, like polyenes, morphylines, etc. We use only topicals if there is a very superficial fungal infection of limited extent. The advantage is low cost, low incidence of drug interactions, and fewer side effects and complications compared to the oral agents. It is also indicated in pregnant and breastfeeding women, because we don't want to expose them to the systemic antifungals unnecessarily. We also give topical agents in patients where we have the risk of side effects, like old patients, geriatric patients, the patients on polypharmacy, etc. The topical antifungals are typically applied on the affected site, and they also have the advantage of having anti-inflammatory effects, like the allylamines and cyclopyroxolamine and the azoles. All of them have antifungal properties also. So we don't need to jump to steroids. Give them a little time and they will reduce the inflammation also. Out of the topicals, the luliconazole and amrolfin have really emerged as the front runners to fight the current fungal menace. So they do not have much of resistance developing against them. So they can be used in combination with oral azoles or oral allylamines like terbinafine. Now, we use oral therapy when there is widespread or extensive infection, when there is chronic infection, when there is intolerance or failure to topical therapy, particularly in onychomycosis, tinea capitis, and in immunocompromised patients. And these are the systemic antifungals that are available, out of which itraconazole has emerged as the treatment of choice these days, because this is showing the least resistance. It is a lipophilic drug which accumulates in the tissues very quickly, particularly in the skin, nails, lungs, etc., and it stays in the tissue for a long time, even after stopping the drug. For example, in that fingernails, it has been found that after stopping the drug, the drug remained in the nails for up to 9 months after stopping it. So that's a big advantage. Now, there are some tips on tackling the fungal menace. One is you need to have counsel your patients and tell them to strictly adhere to the treatment schedule. Wash the towels, clothes, socks, pillow covers, bed linen very, very frequently. Wash clothes and bed linen in hot water. 60 degrees centigrade is when the fungal spores are killed. And then you dry these clothes and linen in sunlight. Sunlight is the best way to kill the fungal spores. Even ironing of the clothes inside out also helps to kill the spores. You need to wear well-dried inner garments which have been washed at least 3 to 4 days prior to wearing, and then dried in sun. There should be no sharing of soaps, towels, clothes, and bed linen. Tight-fitting clothing and tight-fitting footwear should be avoided as much as possible. The patients who are prone to infection or have infection should bathe at least twice a day and thoroughly dry their body. Females with excessive dermatophytosis should avoid cooking in warm or hot environments. Regular removal of hair on the genitalia should be encouraged, and dusting and wet mopping or vacuuming of the house should be preferred over, broom sweeping of the house, because that can spread the spores. Now, in a country like India, it is becoming amply clear that experience-based treatment of dermatophytosis is what is proving to be effective. So we have now evolved our therapies. What used to be, conventionally given for 2 weeks, 3 weeks, now we give antifungals for up to 4 to 6 weeks. And even after that, we continue the topical treatment for at least 3 to 4 weeks after the complete remission of the disease. One of the reasons for recalcitrance is early stoppage of treatment. So give it for at least 3 to 6 weeks, depending upon the area of involvement, and then you will have good results. There's this good rule of 2 that has been coined for effective application of topical antifungals, where they say that you need to apply the antifungal twice a day, at least 2 centimeters beyond the margin of the lesion, and for at least 2 weeks for complete resolution. So in fact, we need to do it for a longer period of time, but this thing that it has to be applied twice a day and at least 2 centimeters beyond the lesion is an important pointer, which will help you, prevent the recalcitrance of the infection. I don't think this is of importance. Combination recalcitrant tinea pedis, treatment option. Okay. In children, the safe drug is terbinafine, although we do use itraconazole to some extent, but terbinafine is a safer drug, which can be used for orally. In pregnancy, if at all you have to use terbinafine, which is a pregnancy category B drug. Azoles should be avoided. If possible, within the first trimester, avoid oral therapy completely and give topicals only. In addition to giving the antifungals, the adjuvants like moisturizers, because many times the patients have a very dry skin, and that is one of the reasons that fungi cannot be cleared completely. So give good moisturization, give good antihistamines to reduce the itch, because itching and scratching also damages the skin barrier and leads to further, foothold of the fungi on the skin. Sometimes we use keratolytic agents like salicylic acid to remove the superficial, fungi and superficial infections that helps in recalcitrant disease, and try to avoid immunosuppressive drugs if possible. So you should always try to look for the possible cause of recalcitrance in a patient of tinea, where there is fungal infection happening continuously. Use your drugs judiciously as far as possible and for as long as is required. The application should be adequate. The dose and duration of antifungals should be adequate. You may have to combine the drugs depending upon the requirement. Therefore, friends, I close with these take-home messages. The judicious use of available topical and oral antifungals is to be promoted. The rule of 2 that I talked about, topical antifungals, is a very useful rule which will help you prevent recalcitrance of fungal infections. Antifungals should be used for a longer duration than recommended, for at least 3 weeks after the complete remission or complete clearance of the lesions, you should continue the antifungals. Sequential therapy can be tried in difficult patients. So you give allylamine like terbinafine for some time, and then give a azole like itraconazole, and you can better control. Sometimes you may need to combine drugs. So give one orally, give another topically, different drug. For example, itraconazole orally, amrolfin topically. The two together work synergistically. Combination therapy with two systemics should, however, not be done. Itraconazole and terbinafine are preferred oral antifungals. Combination of amrolfin and itraconazole or terbinafine has been found to have a synergistic and additive effect. Potent fungicidal activity of luliconazole is rapid. Moisturizers and antihistamines are a good adjuvant in all these patients. I thank you all for your patient listening, and I would be more than glad to answer the questions if there are any. Yeah, Faraz.
Yeah, thank you so much, sir, for giving out your valuable time and sharing your knowledge on this, sir. I definitely think this session knowledge is going to help all the participants who have joined this session. Sir, I can see, sir, we have received some question from the participant. And if you allow, can I take this question with all your permission?
Yes, please. Yes, please.
Sir, one question is from Dr. Agarwal. He's asking, are there patient compliance issue or a specific factor that complicate treatment outcomes during the fungal treatment and therapies?
Yes, of course, Dr. Agarwal. You see, I talked about the importance of adhering to the treatment and the importance of prolonged treatment in this scenario of difficult fungal infection. So they need to take treatment for at least 4 to 6 weeks. That is bare minimum. Nowadays, we give up to 8 weeks, 12 weeks also, depending upon the extent of infection. So adherence is a very important part of your, and important factor in deciding this about the success of the therapy. So naturally compliance comes into play. People will not be ready to use it for a long time, particularly when they get relief from symptoms. So when they get relief from symptoms, they feel that they don't need to continue with the treatment. So it's very important that we counsel our patients properly and explain it to them that it is extremely crucial to take the right dose for the right period of time to get complete clearance of the disease.
Yeah, thank you so much, sir, for sharing your insight on this, sir. Moving forward, I can see another question from Dr. Snehali. She's asking, uh, are there common misconception about superficial fungal infection, and what they can you often address? What are the basics problem which appears during the treatment?
Now, amongst the general population, the common misconception and the problem is that they are not always very ready to see a proper doctor or a proper dermatologist for their treatment. They'll go to the next door chemist, who will usually prescribe or who usually hand over a combination of a steroid and antifungal, antibacterial. These steroids, although they give immediate relief to the patient, they cause a lot of havoc. They cause decrease in local immunity, which potentiates the infection. Finally, they thin the skin, they cause stria in the skin, and then the initial relief is followed by a severe recalcitrance or severe rebound phenomena, where they will have persistent infection. So the patients and the people at large, and even the doctors, have to be very aware about the importance of avoiding steroids in fungal infections. So steroids should be avoided almost in every case of fungal infection. You may use a mild steroid sometimes if there is a very severe inflammatory reaction, or for patients who are addicted to topical corticosteroids and cannot leave it, then you bring down the class of steroid to a milder steroid, for example, fluticasone, for example, dezonide, hydrocortisone. These are mild, low potency steroids, which you can give for a few weeks along with topical moisturizers and antifungals, and then you withdraw the steroid completely. Steroids are the main problem that we face these days with the patients, and that's the misconception.
Yeah, thank you so much, sir, for sharing your insight on this question, sir. One patient is asking, like, sir, she is 35-year-old female, and once the monsoon get over, and she has fungus infection on her fingers of the leg, like in between there is a watery discharge, like it comes sometimes, and what like it happens every year. Like, what are the like ointments or the medication to be suggested, sir, or any lifestyle? sir, like
Most
suggestion?
important thing would be to avoid frequent washing and to dry it completely and properly after you have washed, because that season is usually associated with a lot of moisture and dampness, particularly in the folds. And that's how and where the fungi, replicate. So fungi are present on our skin. They just need the right atmosphere to grow. So if there is damp and warm environment, they'll easily grow in that environment. So, and they feed on our skin, on the keratin, which is a part of our skin. So they have good amount of food, they have the right environment and temperature and humidity, and they grow. So the most important lifestyle change would be avoid frequent washing, and after every wash, dry your skin properly, apply a good moisturizer, and one of the azoles like luliconazole, like oxyconazole, like ibuconazole, all of them are good antifungals for the folds of the skin or the webs of the fingers and the toes, because these are usually affected by fungi like Candida, which responds better to azoles like luliconazole, like ibuconazole, like oxyconazole, etc.
Thank you so much, sir, for answering all the questions, sir. I can see one feedback from Dr. Snehali. She's written wonderful presentation. Thanks for discussing the major problem of skin. I hope she really enjoyed this session, sir.
Thank you, sir.
And yeah, welcome, sir. Like moving forward, sir, I can't see any questions, sir. As there is no more question, with all your permission, shall we conclude this session for today?
Yes, please.
Yeah, thank you so much once again, sir, and I hope to see you again with different topic in future, sir. Till then, take care of yourself. Thank you once again for sharing your valuable time with us.
Thank